Hello, this is Amir, a hematology registrar again with daily hematology bleeps. Our today's topic is neutropenia. Um, you will be receiving a lot of calls from different departments regarding low neutrophil count as a hematology registrar or hematology consultant. Yes, neutropenia is sometimes concerning to us. It can be temporary or it can be persistent one as well. I should not say permanent. It can be temporary or a persistent neutropenia. The persistent neutropenia is the one which is a bit worrisome for the hematology people because they may have underlying hematological disorder. So, neutropenia has a lot of causes. Um, for example, if someone has a flu virus, the virus can suppress the bone marrow production of neutrophils. In a simple language, you may see people with viral infections, flu, sore throat, they can have neutropenia as well. But this one is temporary, uh, and not persistent one. So once the flu is over, then your neutropenia recover as well. Second common cause of neutropenia is the hematinic deficiency in the people, depending upon the people habit of diet or their nutritional intake. So it's important to check the MCV of the patient as hematology register, and the medical team or the referral team can also keep an eye on MCV as well, and they can check the B12 and folate of the patient as well. If it is low, it can be a cause of neutropenia as well. The other causes of neutropenia, like mild neutropenia, can be normal in some people as well. We call it as ethnical neutropenia in some of the African population. This is normal. The neutrophil counts always remain low, 1.0, 1.2, or zero point 0.8, like that. This is normal for their body. Their body is adjusted to that. Okay, no need of further investigation in these patients. I mean, invasive investigation in these patients if the common investigations are normal. Then, if someone is having any sort of other diseases like hypothyroidism, it can lead to bone marrow suppression and low neutrophil count as well. Neutropenia can be autoimmune as well. Some of the autoimmune diseases are specifically associated with neutropenia, like rheumatoid arthritis is common. It is usually associated with neutropenia, and if they have splenomegaly as well, then this syndrome is called Perthes syndrome that we practice a lot in the MRCP PACES UK exam. So, rheumatoid arthritis, neutropenia, splenomegaly, this is Perthes syndrome. But persistent neutropenia is always worrisome. Contact the hematology doctor for persistent nature of neutropenia. There are other causes of neutropenia as well. And there are quite a lot. Patient may be taking anticonvulsant medications or some antibiotics. They can suppress the neutrophil count in a patient, and that is another cause. Even iron deficiency sometimes is associated with neutropenia as well. So the MCV will tell you, HB of the patient will tell you whether this patient has um, any low iron level in the body or not. Then some of the people may have solid organ cancers and they may be using chemotherapy drugs. Then yes, they can have low neutrophil count as well. And if you are using chemotherapy drugs for arthritis, like rheumatoid arthritis or other type of joint disease in which rheumatology um, can give the chemotherapy drugs, they can lead to bone marrow suppression as well and a low neutrophil count as well. So these are the few causes which are temporary. If you intervene, their causative factor can be found out, and you can address the causative agent, and the neutropenia will recover. But if it is persistent neutropenia, then yes, then you have to inform hematology team, and then hematology has to dig further. What is the cause of this persistent neutropenia? If a patient has a background history of autoimmune disorder and the neutropenia is persistent, then for hematological people and doctors, then there is a condition called LGA, okay, that is associated with uh, neutropenia in autoimmune disorders. You can find out that only after the bone marrow biopsy. So for this purpose, the hematology team has to intervene and follow the patient in the clinic. Neutropenia can be a initial presentation of MDS as well, myelodysplastic syndrome. So that's why when the neutropenia become persistent, then we see the patient in our clinic, in hematology clinic. And if the patient has previous history of chemotherapy, radiotherapy for any solid organ cancer, and now the patient has um, persistent neutropenia, like for more than 3 months, I would say for more than 3 months is significant. And rest of the causes, temporary causes have been ruled out, then yes, then I would follow this patient in my clinic. I will go for bone marrow biopsy to find out why this patient has persistent neutropenia. So the investigations that you should do for any new case of neutropenia is to check this patient routine bloods and a blood film. Blood film will be seen by the hematologist. It will tell you a lot of things. What is the possible cause in this patient? If it is virus induced, usually we see a reactive lymphocytes in the blood film sometime. And if it is other causes of hematological nature, like a large granular leukemia, they have their own specific type of cells, which is called LGL cells, large granular cells, large granular lymphocyte cells, which are hallmark of the LGL leukemia. Or if it is MDS related, then it has its own blood picture, which will be seen by the hematology doctor, not by you guys. So a routine blood test is important. Send hematinics for the patient, including B12 and folate, and also send iron profile for the patient as well. But if you are not sure what to send, then obviously you have to inform the hematology team. They will advise you accordingly. But this is for your general knowledge if you want to send some test to rule out the cause of temporary neutropenia or reactive neutropenia. You can also send virology screen for the patient because many of the viral infection can lead to bone marrow suppression and neutropenia. You can take a nose and throat swab from the patient for different viruses if the patient has symptoms of upper respiratory tract infection. Then you can send the viral throat swab as well. The TSH and the autoimmune screen in the patient is important to find out if the cause of neutropenia is hypothyroidism or if the cause is autoimmune in nature. So we have talked about the different causes of the neutropenia, both temporary and persistent, and we have mentioned different tests for the neutropenia as well, the hematological and non-hematological causes of neutropenia. It is important that you should see the blood film of the patient as a hematology registrar or consultant in a hope to see for any reactive lymphocytes in viral causes, large granular lymphocyte in LGL in the background of rheumatoid arthritis or other autoimmune diseases, or any leukoerythroblastic picture in the MDS. And the medical team should send tests like uh, routine bloods with RN profile, hematinics, TSH, the virology screen, and ANA or autoimmune screen in a patient to exclude any uh, reactive causes of neutropenia. Neutropenia bleeps are quite common during the winter season when the cold or flu infections are common. And in general, any patient with infection will have some degree of uh, low neutrophil count if it is mostly by the viral viruses. But in most of the bacterial infections, the neutrophil count goes high because it is an inflammatory response. But the viruses generally suppress the bone marrow, where the bacteria, it can lead to high in neutrophil count. So the next question usually people ask, should I give this patient GCSF injection or not, filgrastim injection, or um, the injection which increase the neutrophil count in the patient? Do not take this decision by yourself. Always ask the hematology doctor, because if someone is 20-year-old, came to the hospital with neutropenia, no other cause, no reactive cause in this patient, then you should first think why this patient has developed neutropenia. Maybe there is some underlying hematological cause. And there are some conditions in which you should not give GCSF unless it is decided by the MDT, or in specific situations, like in acute myeloid leukemia, in MDS, myelodysplastic syndrome, and aplastic anemia. We do not give GCSF routinely. Only in certain patients where the MDT decides, and where the benefits are more than the risk, then we can give them GCSF. But the GCSF injection decision should always be discussed with the hematology team. So this was a short talk about the neutropenia and its different temporary and hematological causes. I hope it will benefit you. We will be discussing the bleeps daily, uh, depending upon the nature of the bleeps I received. But if you have any query about these things, bleep hematology. Thank you.